So welcome to the first tutorials of 2016 booklet for Krok 1. So Krok 1, 2016 booklet. We are done with 2015. So today we are starting with 2016. So let us begin. A 35-year-old man has been delivered into a surgical ward with a suppurating wound in the neck anterior to the trachea. By now you should know where your trachea is. So whatever it is, infection that is suppurating, they said it is anterior to the trachea. That is pre-visceral space. Now, if a surgical operation is not performed urgently, there is a risk of infection spreading to which area? Where will infection spread to? Now, when we talk about the pre-visceral space, we are referring to the space that is surrounding the trachea, okay? The space surrounding the trachea and lying against the anterior wall of the esophagus. So, imagine it. Around the trachea and against the anterior wall of the esophagus. So the space in between is what we call the pretrachea or the pre-visceral space. The pre-visceral space. So up until now, you should know what we are talking about anatomically. So now below this space, we have the superior mediastinum. Below it, we have the superior mediastinum. And therefore, if urgent surgery is not performed, or whatever thing that needs to be done is not done immediately, what it means is that it can spread. It can spread to the superior portion of the mediastinum. And of course, that is what anteriorly you will see it. Anteriorly. So it is what? Superior anterior mediastinum. So over here, of course, your best answer should be what? Should be the anterior mediastinum. When we talk about the mediastinum, we're talking about the chest compartment or the middle of your chest, that area. There's a space there. So the spread will go into those areas. So over here, we're looking at what C as our answer. Characteristic sign of glycogenosis. Again, you guys know this question already. Is muscle pain during physical work. Blood examination usually reveals hypoglycemia. Hypoglycemia, that means not enough glucose. This pathology is caused by the congenital deficiency of the following enzyme. I've already explained what glycogenosis is all about. This simply refers to what? Glycogen storage disease. And when we say glycogen, that is the stored form of glucose. So the stored form of glucose is called what? Glycogen. So anytime we are having a deficiency in enzyme, either in its storage or in its release, we call it what? Glycogenosis. We call it what? Glycogenosis or glycogen storage disease. Glycogen storage disease. And of course, with what we are having over here, whereby there is pain due to physical activity or physical work, for example, maybe training. So what comes to our mind is for the fact that we could be dealing with, we call it type 5 glycogen disease or glycogen storage disease, type 5. Of course, we have a lot of types. We have the von Koch and all those ones. But this one is what? Type 5. Type 5. Because don't forget, when you do exercises, you have to break down what? Glucose. You have to what? Break down what? Glucose. And there's a problem with those enzymes that is involved in its breakdown. And that's over here. We are looking at what? Glycogen phosphorylase. Glycogen phosphorylase. Because this phosphorylase is involved in the release and in the breakdown of what? Glycogen. Sorry, of glucose. Through a process called what? Glycolysis. By now, you should know what I'm talking about. So this is what? Type 5. Type 5. Type 5. Type 5. All right. So if I were you, my assignment would have been to go and look for type 1, type 2, type 3, type 4, and even type 6. We have all of them there. We have all of them there. What patient? Why they? The man. Guys, emergency, I'm coming. Guys, I'm coming, okay? Great. So like I was saying, we're having a problem with glycolysis, or we're having a problem with the breakdown of what glucose. And that's what over here we're looking at what glycogen phosphorylase. And I was saying it will be for your own interest to go and look for the other types of glycogen storage diseases. Glycogen storage diseases. Okay. So guys, his vitals are in. Let me just check. Let me pause it. All right. So histologic specimen of a kidney demonstrates cells that are closely adjoined to the renal corpuscles in the distal convoluted tubule. The basement membrane is extremely thin and has no folds. These cells sense the changes in sodium content. Guys, what are you thinking of? Anyone? They sense changes in sodium content. We've done this. What are you thinking about?
Macula densa.
Exactly. You are thinking of what? Macula densa. So this macula densa, when stimulated, it causes secretion of renin from where? From the juxta glomerular cells. And this renin will in turn convert what we call angiotensin converting what? Enzymes, isn't it? And these angiotensins will also in turn activate what we call the aldosterone system. And in the long run, we have what we call the RAS system. The RAS system. Renin, angiotensin, aldosterone system will be what? Activated. So take note of these things. So over here, we're looking at what? At macula densa cells. So don't confuse the function of macula densa with juxta glomerular cells. And podocytes. Podocytes are like finger-like projections that serves as a protective mechanism for the, how do you call it? The nephron, if I should put it that way. Also helps in filtration, basically. But the messenger cells serves as a protective mechanism. So please take note of these things. Biological analysis of a tap water has resulted in the following. Bacteria count in 1 ml of water is 80. The quality index is 3. What would be the conclusion? What would be the conclusion? So over here, you need to know what color index is, or coli index is. So coli index simply describes the number of coli in 1 liter of water. I repeat, it describes the number of what? Coli. I'm talking about coli, I'm talking about microorganisms, or E. coli, but the standard is what? The coli or the E. coli. So you want to determine what? The total percent or the total number of these coli in 1 liter of water. Now, a good drinking water should not have more than 100 microbes in 1 ml. I repeat, a good drinking water should not have more than 100 microbes in 1 ml. So please take note of that. Take note of that. And over here, we are having what? What is the color index? Color index what? Is just 3. The color index is just 3. But that will also mean that we are having the total bacteria is what? Is 80. Isn't it? The total bacteria is 80. 80. And of course, with 80, which is more or less than 100, we can say this person or this water is actually what? Safe for us to drink. Is safe for us to drink. And so therefore, we can go in for what? Water is safe for consumption. Water is safe for consumption. So basically, that is what we'll be looking at in this question. the process of metabolism in the human body produces active forms of oxygen, including superoxide anion radical. This anion is inactivated by the following enzyme. Guys, even if you don't know what this enzyme is all about, just by looking at the name should give you that. And usually, a lot of biochemistry, the name of enzyme actually constitutes the substances or the substituent that you are using to do the reaction. I don't know if I'm making sense. But what I'm trying to tell you is that usually the name of the enzyme that catalyzes the reaction, the name, one or the other, comes out from the individual element or the individual substances that are what reacting. And that's over here, even without knowing what superoxide is, we can definitely say that we are having what? A superoxide dismutase. This enzyme is inactive, and that is why the body is producing what? A lot of what? Oxygen. That is reactive oxygen, which are not good for the cells. So here the answer is what is E. Okay. The same if I say peroxidase, it should tell you that I'm talking about the peroxide. If I talk about glutathione, you should know what I'm talking about. What kind of muscle contraction occurs in an upper limb during an attempt to lift a load beyond one's strength? Good. So you are lifting a load beyond your strength. What kind of contraction occurs? And let me take my time to go through one or two things with you, like isometric and isotonic kind of contraction for you to know the differences. Now, we'll talk about isometric contractions. Isometric contractions, they generate force without changing the length of the muscle. Isometric. You are generating force, but there's no change in length of the muscle. No change in length of the muscle. That is isometric. That is isometric. Now, an example of an isometric contraction will be carrying an object in front of you. So you are carrying an object, so you can just test it yourself. Maybe find something in your room, something a little bit heavy in your room. Just position the object in your hands, just be stiff for some time. You realize that you are generating force, but there's no change in the muscle length. No change in the muscle length. The same way, the weight of pulling an object, the weight of the object would be pulling downwards, but your hands and arms would be what? Opposing the motion with equal force going upwards. I'm still trying to explain the fact when you're holding something in your hands. Okay, so when holding it, after some time you realize that a force is trying to bring it down, and that is because of what? Gravitational force acting upon it to come down, and your hands or your arms will try to what? Stabilize it in the air as it's supposed to be, even as little as the phone. At a point you realize that there's pain in your in your muscles, isn't it? But there's no change in contraction. I mean, there's no change in length of the muscles. And that is called what? Isometric sort of what? Contraction. Isometric contraction. And of course, if you look at, now the opposite is true for isotonic what? Contraction, whereby there's generation of force by changing the length of the muscles. Changing the length of the muscle. And under isotonic, we can talk about the concentric and then the eccentric form of contraction. I don't want to go into details of some of these things. Okay. Now, assuming you are lifting a metal for the guys who like to gym, or for anyone who loves to gym, when you begin to gym, you realize that sometimes you can feel that your muscles are increasing in length. Even one day of gymming, you can feel that your muscles are, they've done something. And that is what isotonic. isotonic. But in isometric, Charlie, you are pulling, but nothing is happening. With all the force, but nothing is moving. That is what? Isometric. So, of course, this particular question, whereby you are lifting a load beyond your strength, what it means that you are not able to lift it up. So no matter the force you are applying, nothing is moving. And that is called what? Isometric form of what? Contraction. And that's over here, you are looking at isometric. Isometric. So your answer is A, isometric. A patient suffers from high fever, apnea, pain in the thorax, periocentesis. So first of all, what is a periocentesis? A periocentesis has to do with removal of fluid from the pleural cavity. Removal of what? Fluid from the pleural cavity. And I'm saying that, and of course, anytime you draw periocentesis, you need to analyze the fluid, whether it is an exudate or it is a transudate. Exudate or transudate. When we say transudate, we are referring to the accumulation of fluid inside the pleural cavity as a result of maybe too much pressure in the vessels. Too much pressure. But when we talk about, how do you call it? I mentioned what and what. Transudate, we talk about exudate. And exudate deals with the accumulation of fluid as a result of inflammation. That is what an exudate. And anytime we have the formation of an exudate, to be specific, a pus formation formed inside the pleural cavity, that term is called empyema. I think I was explaining it the last time. Someone asked me either it's here or Krok 2. So I explained that is what empyema. Empyema. So when the fluid inside the pleural cavity is made of what? Pus or pus, that is called what? A pleural empyema. Pleural empyema. And one of the causes of pleural empyema can be what? A pneumonia. Pneumonia can cause empyema. That's why you take pneumonia very what? Seriously. Pneumothorax, all of these things can lead to what? Empyema formation. So therefore, over here, for us to have a yellow-green viscous liquid, tells us that there's a sort of what? Inflammatory process happening over here, which is actually what? A pus formation. And so therefore, your answer will be here. Your answer here will be what? A pleural empyema. Pleural empyema. So your answer is A. All right. Good. Anytime I see acidosis alkalosis, I know it's a bonus question for you guys. So now a patient suffers from a disrupted patency of the airway at the level of the small and medium-sized bronchial tubes. What changes of acid-base balance can occur? What changes of acid-base balance can occur? So over here, first of all, are you going to have hypoventilation or hyperventilation? Who can tell me? We are having a disrupted patency of the airway. That means the airway is not that opened for air to pass through, isn't it? So are we going to have increase in ventilation or decrease in ventilation? Who can tell me?
Hypo, decrease.
Hypo, exactly. So you're going to have what? A hypoventilation. Why? Because of the disrupted patency of the airway. And when there is a reduced ventilation or there's hypoventilation, what builds up in your body? Who can tell me? What builds up in the body? I can't hear you.
CO2.
Exactly.
CO2.
So you are talking about CO2, carbon dioxide, will be built up because it's not being able to be excreted out of the system because of what? The patency. Because of the disrupted patency. So agent of gases, perfusion is not going on what? Very, very well. So if you are having a build-up of carbon dioxide, what are you going to have at the long run? You're going to have what we call what? Acidosis. 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 So the opposite is true. for alkalosis, whereby too much of oxygen will now cause the blood to become what? More alkaline. So please, and this will not be talking about metabolic because this has to do what? With airway. It has to do with what? Respiration. So this is what? Respiratory acidosis. Respiratory acidosis. In metabolic, you know what it is. Where we have the diarrhea, where we have the vomiting, where we have the metabolism of how do you call it? Diabetes. Glucose. All of these things are way of what? Metabolism or excretory, if you want to put it that way. So over here, we are looking at what? At a respiratory acidosis. So always analyze it. Hypoacidosis, hyperventilation, alkalosis. Vomiting, because of you have the taste of acid in your mouth, you conclude that you're going to have what? Alkalosis. Then in diarrhea will be the opposite. You have what? Acidosis. That is how you learn. All right. Upon toxic damage of hepatic cells. So this guy that we are having now, that I was talking to you about, who is drinking, alcohol abuse. Upon toxic damage of the hepatic cells, resulting in a disruption of the liver function, the patient developed edema. Guys, do you remember when I was saying that this person can develop edema? Do you remember? I was talking to you about it. Ascites can develop. So this person, we could be talking about this person in this question. That's why I said medicine, you always apply. So in real life, I'm having the case. But over here, we're talking about it like for the exams. But look at it. So if you're having what? A disruption of the liver function, now there's a development of edema. What changes of blood plasma are the main changes of edema formation? Are you okay? All right. So the question now is that what is the mechanism of the edema development? And again, we've discussed extensively on edema formation. We've discussed this. We talked about oncotic pressure. We talked about hydrostatic pressure. We talked about all of these things. We talked about them. So please don't get confused. However, in a case where you are having what? A disrupted liver function, first of all, what controls oncotic pressure? Who can tell me? Guys, we've done this thing. I even drew a diagram. What controls oncotic pressure? Yes?
Protein, see the proteins?
What kind of proteins? Because all these here are seeing our proteins. What kind of proteins?
Albumin.
Exactly. So albumin is the highest, let me say, substance that is made of a protein. Albumin is so you take a protein, the highest content is made of what? Albumin. It's made of what? Albumin. So always you are thinking of what? Albumin. So albumin is what controls or maintains oncotic pressure in the blood. And we know that albumins or proteins in general are produced from the liver. So now that we are having a liver problem, what it means is that we are not having a lot of what? Of the albumin being produced to be inside the blood vessels. And because there is low amount of albumin or low amount of oncotic pressure or decreased oncotic pressure, fluid begin to move from the vessels into the interstitium. And that's why I was saying that it's just a matter of time. This guy can develop what we call ascites, which is just another term for what? Edema in the abdomen. So we become what? A male who is pregnant. Quote and unquote, a male who is pregnant. So that's what we're going to be looking at. So over here, we are going to be looking at what? A decreased what? Albumin content. That is the mechanism of the development of the edema. Decreased content of albumin. Why? Liver, proteins, oncotic pressure. Please never forget that. All right. I don't want to go into the other one, hydrostatic pressure, because we have talked about them. So please do well to watch the, how do you call it? The basis that we have done. I think this will be under physiology or pathophysiology. Please Take your time and go through these things. They will help you. A 6-year-old child was suspected to have an active tuberculosis process and has undergone Mantox test. What immunological preparation was injected? So Mantox test, and of course, you know your answer is what? Tuberculin. Tuberculin. Someone was asking me, what then is BCG? Like you can see, BCG is a vaccine to prevent the occurrence of tuberculosis. But tuberculin is the test that is used to determine whether there's tuberculosis or not. But the process is called what? The Mantox test. So please don't get these things confused. So we're having what? C as our answer. A 15-year-old boy has been diagnosed with acute viral hepatitis. Guys, you remember I was telling you something about AST, ALT, isn't it? And some of you rightly said the right answer. There could be what? Problem with the liver when you have AST, ALT. But let's look at the question again. The same person was diagnosed with acute viral hepatitis. What blood value should be determined to confirm acute infection, not affection, acute infection, acute infection of the hepatic cells? And of course, you are going to look at for what? For the AST and then ALT. AST and then ALT. However, it's not only in the liver that you check for AST and ALT. Even inside the lungs, inside the heart, you can also check for what? AST and ALT. Please take note. Inside the heart, you can also check for what? AST and ALT. Of course, we have troponin that you can also check and all of those things. But there's a difference between the AST and the ALT in the liver and then the AST and the ALT in the heart. But don't worry, I shall tell you when we get there. Okay? But just put it at the back of your mind. But I shall explain to you when we get there. The differences, I'll give it to you. But whichever way, we must have what? High AST, ALT to confirm that we're having what? A viral hepatitis. A 53-year-old man is diagnosed with Paget's disease. Concentration of oxyproline. Those who were with me under biochemistry, you can remember oxyproline. So if you see oxyproline, what comes to mind? Let's assume you don't know what Paget's disease is. But when you see oxyproline, what comes to mind? Who can tell me?
Collagen.
Exactly. Collagen comes to your mind. So either you see proline, you see glycine, you see lysine. Collagen comes to your mind. I repeat, lysine, glycine, proline. Collagen always comes to your mind. And of course, a Paget disease is simply a disease or a disorder of bone remodeling. It's a problem with it. And of course, we know one of the tissues that helps in all this bone formation and things like that, or extracellular matrix. Of course, the collagen comes to play. And that's what over here we are looking at what? At collagen as our answer. And of course, in some questions, you might not see oxyproline. You might see glycine. Please, it's the same thing. They are all there. Glycine or lysine. Please, all of these, you can see them in the urine. So take note. So here, your answer is what? Collagen. When taking exams, another easy question. When taking exams, students often have dry mouth. And I think we spend a lot of time on this question. The mechanism that causes this state results from the following reflexes. So you are preparing for an exam. So it is what? Conditioned. You are preparing. So your mind is on it. You are preparing for an exam. So conditioned. Dry mouth is a sympathetic what? Innervation. So obviously, we're having what? A conditioned sympathetic reflexes. Of course, some of you asked me about unconditioned, parasympathetic, and we talked about all of them. So please, don't let me go back. If you really want to grasp it very well, please rewatch that video. And I think we even saw one in 2015 booklet, if I'm correct. Anyway, it's been long, but I think so. A patient has hoarseness of voice. During laryngoscopy, a gray-white larynx tumor with a papillary surface has been detected. So gray-white larynx tumor with a papillary surface was detected. Investigation shows there's a growth of connective tissue covered with multi-layer, strongly keratinized pavement epithelium. No cellular atypia. What is the most likely diagnosis? What is the most likely diagnosis? And of course, over here, you are going to be looking at what? A tumor of the papilloma. Or a papilloma, that's what? A tumor of the what? The papillary. Tumor of the what? The papillary. Which is more like a what? A finger-like structure. Finger-like structure. So the clue here is the fact that we're having what? A tumor with the papillary what? Surfaces. A tumor with the papillary surfaces. That's over here. Simply put, your answer is what? It's a papilloma. Papilloma. Again, in pathology, some of the descriptions always you can find your answer always in your question, because we describe things according to what the anatomical or according to how you see the thing. All right. During autopsy, approximately 2 liters of pus have been found in the abdominal cavity of the body. So there's pus formation that is found in the abdominal cavity. Peritoneum is dull and of grayish shade. Serous tonic of the intestine has a grayish colored coating that is easily removable. So first of all, someone is going to tell me the type of inflammation we are having over here. Who can tell me? A grayish coating. What comes to mind?
Fibrinous.
Exactly. Fibrinous type of what? Inflammation. And a fibrinous type of inflammation, we have 2 types. We have what? The Krupus, and then we have what? The diphtheric. And with diphtheric, it is not easily removable. But with Krupus, it is easily removable. Very good. Fantastic. So please always put this at the back of your head. So of course, so if you are thinking of what a fibrinous type of what inflammation, without even going to the question, you wouldn't know how you answer. So what type of peritonitis has developed? Again, use the type of inflammation occurring to describe this. As simple as A, B, C, D. And that's what over here, you can easily see we are having a case of what? Of fibrinopurulent peritonitis. But if they really want the real answer, this is what? Krupus. If they want the real answer, this would what? A Krupus type of what? Peritonitis. Krupus or fibrinopurulent peritonitis. All right. So your answer is what? Is C. Guys, there's no bleeding, so stop thinking about hemorrhagic. There's no sign of tuberculosis, so stop thinking about tuberculosis. Nothing. Now, when we say serous means that the exudate is of the same color like or it's clear. Let me put it that way. It means the exudate is clear. Now, when I say exudate, you know what exudate is. Exudate means what? Any kind of what fluid that is as a result of what inflammation. That's an exudate. So please, when I start mentioning some of these things, don't get confused or overwhelmed. Autopsy of a body revealed a bone marrow hyperplasia. Bone marrow hyperplasia. That means it is overgrowing. Whatever cells is there is overproliferating. But look at it. They said of the tubular and the flat bones. This is your clue. That's myoid marrow. A myoid marrow. There's splenomegaly, hepatomegaly, enlargement of all lymph nodes. What disease are identified? What disease are the identified changes typical of? So first of all, you know that we're having a leukemia because they've told you that we're having a bone marrow hyperplasia, you know that bone marrow is the primary site for blood regeneration. For blood regeneration. So all your blood are coming from the bone marrow. All your blood is coming from the bone marrow. So that is where regeneration takes place. So if you're having hyperplasia, that means you're going to have what? A leukemia or a blood cancer. Leukemia means blood cancer. And of course, under leukemia, you can think of what? A lymphocytic origin or a myelogenous origin. Lymphocytic origin or myelogenous origin. These are all pathways or differentiation path for cells. So the lymphocyte eventually end up in lymphocyte, whilst the myelogenous eventually end up with the neutrophils that you are seeing or you see around all the time. So now the question is that how do we differentiate between these two? So over here, the main clue here that is helping you with your diagnosis is the fact that we are having this hyperplasia occurring in flat bones. And this is typical for myelogenous leukemia. Again, this is typical for myelogenous leukemia. And that's what over here we are going in for what? For a myelogenous leukemia. So the opposite, of course, will be for what? For lymphocytic. And again, sometimes in the cells, they will tell you that lymphocytes are more or myelocytes are more. You know, all of these, they can be telling you all of these things. So please take note of, some of these stuff. Okay. And another clue that can also help you is the fact that we also have what? Organomegaly in a chronic myelogenous leukemia. We have organomegaly that include the liver and the spleen. We can even have a painless lymphadenopathy. Painless lymphadenopathy. So all of these characterizes what? A myelogenous leukemia. And like I said, the opposite will be true for a lymphocytic leukemia. So over here, your answer is what? Is B. A pathological laboratory has been investigating a sample of a homemade dried fish that was the cause of severe food poisoning. Microscope of the culture inoculated in a kit Tarozzi medium revealed a microorganism resembling a tennis racket. Guys, you don't need God to come and tell you your answer. Tennis racket is just describing what? Clostridium botulism. Botulinum. Clostridium botulinum. But the disease is called what? Botulism. So over here, we are looking at what? At botulism. Now let me ask, what media will be for cholera? Who can tell me? What media? What do they use? Peptone, alkaline peptone. Very good. Now I said this because we might see something similar very soon. All right. So we have an infant who has been diagnosed with microcephaly. That means small what? Brain. Literally. Okay, microcephaly. The brain is not well developed or it's kind of small or a small head, let me put it that way. Now, doctors suspect that the brain is underdeveloped due to the fact that the mother had been taking actinomycin D during her pregnancy. So what germinal layers have been affected by this teratogen? Now, you hear that when some people are pregnant, there are some drugs we don't give them. Because we give them, we might cause what? A teratogenic kind of what? Malformation. It can alter some things, and when they come out, they look different. Okay. So the question is that what germinal layers have been affected by this teratogen? And don't forget, we are saying this person have what? A microcephaly, or basically impaired brain development. And of course, You know all this, that we have about 3 layers: the mesoderm, the ectoderm, the endoderm. We know all of these layers. These are the germinal layers. But let me take, let's go to each and every single one of them so that we can know which or what they differentiate into. So we will start with the ectoderm. So the ectoderm differentiates to form the nervous system. So if I were you, I'll be writing these things down. The ectoderm differentiates into the nervous system. That includes the spine, the peripheral nerves, the brain, and also it develops into the tooth enamel. So your tooth enamel, the epidermis, that is the outer layer of your skin. Your skin. All of these things are as a result of what? The ectoderm differentiation. Don't forget, even your mouth, your nose, your nostrils, your sweat glands, your hair and nails, all of them, ectoderm. Write them down. Now, mesoderm. The mesoderm literally differentiates to form the circulatory system. The mesoderm differentiates to form the circulatory system, the lungs, the skeletal system, the muscular system. So we start talking about the muscles, skeletal system, the lungs, circulatory system. We are dealing with what? The mesoderm differentiation. Whilst the endoderm differentiates to form the digestive system, the liver, the pancreas, the lungs. All of these things are because of what? Endoderm. So please, if I'm too fast, just do your best, possible best, and rewind everything. Rewind. That's why we're recording it. So rewind everything. All right. So we're talking about the ectoderm because we're referring to what? Brain, ectoderm. So what part differentiate to form the muscular system? Who can tell me? What germinal layer?
Mesoderm.
The mesoderm. Very good. It means people are listening to me. That's great. A patient demonstrates sharp decrease of pulmonary surfactant. Who can tell me the types of pulmonary surfactant that you know? 2. Type 1, type 2. I gave you guys an assignment to go and look for the how do you call it? The function of type 1 and type 2. I will not still tell you. Go and look for it. All right. So this condition can result in, so if you're having a surfactant deficient, what it means is that, now one thing that the surfactant does is that it helps in surface tension, okay? So it prevents collapse of the lungs. So if you're having deficiency of the surfactant, that means surface tension will be impaired. And when surface tension is impaired, the lungs can collapse. And the reason it is collapsing is because the lung cannot open back or cannot, your lung is able to coil. It's able to coil, okay? Or how do I put it? Yeah, coil. Yeah, basically. So when there's a problem with the surfactant, what it means is that ability will be impaired. And so therefore, we're going to have what we call an alveolar tendency to reside. In other words, to return back to its normal form. And that can lead to a collapse of the lungs. And that's when newborn, preterm babies are born. What do? We give them dexamethasone. Why do we do that? We give it to them so that they can develop or it can help in the growth of the surfactant. So please, if you don't know, just put it at the back of your mind. Preterm babies, we give them dexamethasone to help them develop or mature the surfactant so that they can respire or breathe normally. So the answer here is A. A patient is diagnosed with a diabetic coma. Sugar 18. what glucose regulating drug should be prescribed in the given case. This is a severe case. So what are you going to give? Who's telling me the answer? Quick.
Rapid acting.
Rapid acting. Exactly. If you're going to use long acting, you're going to kill the patient. So rapid acting. Rapid acting, please. Initial inoculation of water in 1% peptone water. I will not continue again. What's your answer?
Cholera.
Thank you. Thank you. If you understand things like this, you don't waste you don't waste your time on questions. It has been determined that one of the pesticide components is sodium arsenate that blocks lipoic acid. What enzyme activity can be impaired? What enzyme activity can be impaired? Name this enzyme. We talked about arsenate. So we said that the arsenate blocks or is the lipoic acid is more or less like a cofactor of enzyme E2. When I say E2, some of you are confused. But when you take what we call a pyruvate dehydrogenase enzyme, this is a complex enzyme, okay? A pyruvate dehydrogenase enzyme is a complex enzyme which consists of 3 different enzymes. So we call it what? A multi-enzyme. Okay, it's a multi-enzyme. A lot of enzymes come together to form one. So it's a complex. Now we have the E1. So the E1, what comes to mind? You are thinking of what? Thymine pyrophosphate. That's the TPP. That is what? Vitamin E1. Sorry. Enzyme E1. TPP comes to your mind. Then on top about the E2. The E2, then you are thinking of what? The lipoic acid. You are talking about the lipoic acid and coenzyme A. This comes to mind. Lipoic acid and coenzyme A. Then on top about the E3, we are referring to what? The NAD and then the FAD. NAD and then FAD. If you don't know what NAD is, FAD is, please go and check them out. Check them out. NAD, FAD. They are all types of vitamins that serves as a cofactor. So again, if this lipoic acid, which is supposed to be part of vitamin E, I'm not licensing vitamin, which is supposed to be part of, anyways, they're all made up of vitamins, which is supposed to be part of E2, is deficient or is being blocked. What happens? What it means is that the whole enzyme would be malfunctioned. The whole enzyme will be what? Malfunctioned. And that's over here. What comes to our mind is what? The pyruvate dehydrogenase complex. But actually, the real enzyme is what? Is the E2. Is the E2. Is the E2. Is the E2. All right. An infant born prematurely 2 days ago. So again, someone who is born prematurely, what will you give to the person to help with surfactant development? I mentioned it. Who can remember? Oh, if I've forgotten. Dexamethasone. Exactly. It's a glucocorticoid, anyways. An infant born prematurely 2 days ago presents with a yellow coloring of the skin and the mucosa. Such a condition in the infant is caused by the deficiency of which of the following enzymes? Guys, we've talked about this like million times. So we are having what? Now this person is developing a yellow coloration. Now when you have a yellow coloration, what does it mean? What chemistry are they talking about? Who can tell me? What are you talking about? Jaundice.
No?
But jaundice is because of increased amount of what?
Bilirubin.
Bilirubin, of course.
Bilirubin, yeah.
Exactly. So don't forget bilirubin. And don't forget we said that we can conjugate it or what? It can be conjugated or non-conjugated depending on the mechanism of the jaundice, the jaundice development, isn't it? But for a premature baby, what we are likely to find is what? Is the UDP glucuroniltransferase. Glucuroniltransferase. Actually, this enzyme is what helps in what? Glucuronation or conjugation of bilirubin. Take note. These enzymes helps in how do you call it? Conjugation of bilirubin. So please take note. So we're going to have that deficiency. So the answer is what? Is C. Is C. A 50-year-old woman diagnosed with cardiac infarction, that is myocardiac infarction, has been delivered to an intensive care ward. What enzyme will be most active during the first 2 days? You remember when I was talking to you about AST and ALT, isn't it? And I was telling you that it can also be found in the heart. So now this is our question. So what enzyme will be most active? Obviously, we can have ALT and then what? The AST present. But which one of them will be more in the heart? And which one will be more in the liver? That's the little clue I want to give it to you guys. So in the heart, we are going to have a lot of what? Aspartate. Heart, aspartate. Then in the liver, we are going to have a lot of what? Alanine. So please just take note. Even though both of them will be high, but the one with the highest one would be what? Aspartate, if you are thinking of what? The heart. Then in the liver, you think more of what? Of alanine. So please take note of that. Take note of that. So over here, increase what? Aspartate. Your answer is E. Write it down if I were you. Because it's a new information, so write it down. The more you write, the more you're likely to remember. A stool culture test of a 6-year-old bottle-fed baby revealed a strain of intestinal rod-shaped bacteria of antigen structure 0111. Guys, what diagnosis can be made? This one, there's nothing like explanation. Okay, it's just a strain. Just like me saying we're having a staphylococcus. I mean, as a microorganism. The same thing. Of course, this is a staph infection, isn't it? The same way when you see an antigen structure of 0111, we are definitely thinking of what? E. coli enteritis. We are thinking of what? Enteritis. So your answer here is what? Is C. Coli enteritis. Patient of a sick 5-year-old girl visited a genetic consultation. A karyotype investigation revealed 46 chromosomes, which is good. Now, on one chromosome of the 15th pair was abnormally long. That means something has come to add to it. That's why it's abnormally long. Now they explain again. Having a part of the chromosome belonging to the 21st pair of chromosome. What mutation has occurred? Guys, one has moved from chromosome 21 to chromosome 15. Even if you don't understand, just use English to get your answer. This is what? A translocation. Duplication is the same, how do you call it? The same chromosome doubling itself. That's what duplication. Okay, deletion means part has been taken out. So we can say in chromosome 21, there's a deletion. So in 21, there's a deletion. One has disappeared. They should wait. Quinoa. Definition. All right. So, like I said, this is what a translocation. Now, when we say inversion, it has turned 180 degrees. That is what inversion. Deletion, something is gone. Translocation, move from one place to another. Duplication, it has doubled. As simple as that. So here we have what? Translocation. A patient consulted a doctor with complaints of dyspnea occurring after physical exertion. So this dyspnea is, now this means shortness of breath, okay, after physical exertion. Physical examination revealed anemia, paraprotein was detected among the gamma globulins, paraproteins, plenty proteins? What value should be determined in the patient's urine to confirm the diagnosis of myeloma? The diagnosis for what? Myeloma. Now, when we say a paraprotein or myeloma or plasmacytoma, we are referring to what? Proteins with an abnormal immunoglobulins. Proteins with abnormal what? Immunoglobulins. Basically, that's it. And of course, to check for this, you use what we call what? The Ben-Jones protein. The Ben-Jones protein. If you are dealing with copper, you use what? The ceruloplasmin. Ceruloplasmin. That's for copper. People with Wilson disease, you use what? Copper. That's what ceruloplasmin. But if it is myeloma or plasmacytoma or paraprotein, please use what? Ben-Jones protein. Ben-Jones protein. All right. A patient complains of dizziness, thirst, difficulty swallowing, and impaired vision of close object. A patient complaining of has addressed a doctor. Okay. The respiratory rate is increased. Pupils are dilated. General agitation, talkativeness, tough, though the speech is indistinct. BP 110/70, heart rate 110. Given symptoms can indicate overdose of the following drug. What drug was overdose? What drug was overdose? So again, we're having what? Dizziness, test, vision impairment. We're having what? Pupils being dilated, respiratory increasing, agitation, talkative, speech indistinct, and so on and so forth. And usually we are looking at for what? For atropine. Atropine sulfate. Atropine sulfate. And you know, the normal function of atropine is used to treat bradycardia. So for her, maybe the person was having what? A bradycardia, and they gave the atropine injection. So that will increase everything. So it is used to treat bradycardia, used to reduce salivation. And of course, excess dose or side effect will give you the palpitation, the dilated pupils, restlessness, thirst, dry skin, swallowing difficulty, tremors, fatigue, and problems with coordination. Aha. So over here, we are going to be looking at for what? For atropine. Atropine. So the answer is D. Atropine. All right. A dry cleaners worker has been found to have hepatic steatosis. We've discussed this. Hepatic steatosis. Fatty liver. Now, this pathology can't be caused by the disruption of the synthesis of the following substance. Guys, who can remember this answer? You are thinking of what? Exactly. So, exactement. That's French. So you are absolutely what? Right. Why? Because we're having what? A fatty liver. And we said one of the things that you can find in a phospholipid is what? Is choline. One of the things that you can find in a phospholipid is what? Is a choline. So anytime we are having an absence of a choline, and don't forget, I explained that every membrane is made up of what? A biophosphate what? A bilipid layer. A bilipid what? Layer. This lipid layer contains the choline. Okay. So when we have absence of choline, what it means is that the whole enzyme, that's the phosphatidylcholine choline, will be impaired. And when that thing is impaired, the cell membrane or the tissue will begin to what? To be disrupted. And that's what there's now what? Liver steatosis or fatty liver. All right. So here we're having what? D, phosphatidylcholine. All right. A 35-year-old man with a peptic ulcer has undergone antrectomy. That means removal of the antrium. After the surgery, secretion of the following gastrointestinal hormone will be disrupted, will be interrupted. So the question now is that what hormone is found at the antrium of the stomach? Who can tell me?
Gastrin.
Gastrin. Exactly, gastrin. So basically, your answer is what? It's gastrin, because gastrin is found over that area. So if that area is removed, of course, parietal cells that are located will also be taken out. And when the parietal cells that are responsible for gastric juice production is removed, what happens? A problem. So here we have what? E as our answer. Gastrin.